it's been a little while since we've posted a video, but so glad you're joining us. This is TrueFem, and we are joined again by Dr. Margo Anderson. She's done a couple videos with us. So if you have questions about all these women's health topics that like PCOS or infertility or whatnot, you should peruse some of the other videos that we have done. But today I'm pretty excited because this is a topic that I have been excited to do with Dr. Margo because I get a lot of questions about endometriosis. So we're going to dive into that today, learn a little bit about it so that you can feel empowered to advocate for your health as you are on your fertility journey. So thank you, Dr. Margo, for being here. And before we get started, I have to tell everybody who you are because you're pretty impressive. So Dr. Margo is a board certified family medicine physician, and she currently provides direct primary care near New Orleans in Louisiana. And as a direct primary care physician, Dr. Anderson works with patients in person and via telehealth, which is pretty cool, and in an intimate way that allows for an ongoing relationship. And that provides meaningful and individualized care for each patient. Dr. Anderson has special interest in preventing or reversing disease through lifestyle and completed the integrative medicine residency program through the University of Arizona. She has particular passion for caring for women with a focus on hormones and fertility, and she is a certified NAPRO medical consultant. Again, Dr. Margo, we are so lucky that you are here with us today, so thanks for making the time to educate us on endometriosis today.
Thanks for having me. It's always awesome to speak with you.
Yeah, I'm really excited about this conversation because like we were chatting before I hit record that I have a lot of patients right now that have a lot of questions about this topic. And it's one of those ones I feel like you can do a lot of hunting on the internet. And sometimes it's nice to have a one-stop shop like this interview where you can get the information that you need. So it'll be good. So the first question, I think we should just dive right in because I have a number of questions for you. But the first one, endometriosis, in basic, normal human terms, what exactly is this condition and why does it happen? Is it a genetic thing? Like, why does this happen?
Yeah, so endometriosis, the basic definition is that you have endometrial-like tissue growing outside of your uterus. So your uterus, the lining, the inside of the uterus, we call that the endometrium. It's a special word for that. And everywhere in your body, like for example, your muscles have a certain type of tissue that's muscle tissue. Your brain has brain tissue, like a way that's unique to that area. So your uterus, the lining of your uterus called the endometrium, has a special type of appearance. And then what happens in endometriosis is they go in, they might do surgery on someone, they find this endometrial-like tissue in spots where it's not supposed to be. So it's not in your uterus, it's growing either on your intestines, inside your abdominal cavity somewhere, it just not doing what it's supposed to do. Why does it happen? That's really still up for debate. There's some different theories. There's an old theory that they called the retrograde menstruation theory that really people are kind of pushing that one aside, not as much. Some of the newer, thoughts about is definitely there could be genetic predispositions to it, and then there's something we call epigenetics, which means okay, you have these genetic set up, but then based on different environmental influences, things you're exposed to, things you eat, things you breathe, that might change how your genetics play out. So it might influence whether one person gets endometriosis or not, or maybe it was something even that happened when you were developing in the womb, what you might have been exposed to. And another thing we do know is that endometriosis is an inflammatory disease, so there's probably some, component to that as well. But there isn't a definitive answer why, one person gets endometriosis.
Yeah, it's interesting just based off of the potentially multifactorial angles that you could look at this, and kind of based off that, how does endometriosis usually present for somebody, and when does that usually come up?
Yeah, so when it presents and when it's actually diagnosed can be very different. And it can present typically even as soon as a woman has her first menstrual cycle. Maybe it won't do that right away, or it won't be as evident, but the typical presentation is painful periods. That's what people usually think about when they think about endometriosis. And painful periods meaning where you want to just lay in bed, you can't get up and go to school, go to work, do whatever you're supposed to be doing throughout the day. You're taking ibuprofen and Aleve and it's not helping. Other symptoms that are common with endometriosis are having pain with sex, having bloating, fatigue, pain with bowel movements. But the thing that is tricky about endometriosis too is that some women have no symptoms at all except for infertility. So that's another thing. You may not even know you have an endometriosis until you're trying to have a baby and you keep trying and there's no baby. And then, if you have a surgery, you find out, oh, there's endometriosis. That can be a cause. So some women will go for a while thinking that, man, I just have the worst periods, but they never actually get diagnosed, because to be diagnosed, it has to be a surgical diagnosis. So that, that most people don't jump right to surgery the first time they have some painful period. And there has to be a tissue sample taken during a surgery, and they look at it under the microscope. That's how they diagnose endometriosis.
Yeah. So it sounds like, I think in your work that you do as a physician and me as a fertility awareness educator, we meet a lot of women with painful periods, right? And some of the potential symptoms that you just described. So is there a good estimate of how many women have this condition? I know there's obviously a delay in diagnosis a lot of the time.
Yeah.
Yeah.
Yeah. I mean, if you look at the statistics, they say about 1 in 10, which is, that's not anything to bat an eye at. That's pretty predominant.
Yeah. And as far as you talked a lot about, or just now about some of the symptoms, and if a woman is charting her cycle, she's keeping track of different biomarkers, whether cervical mucus, obviously keeping track of bleeding and pain, and maybe even temperature, her basal body temperature. Based on your experience, how might endometriosis present in the charting of someone who is tracking their cycle?
Yeah, so some of the common things you might see are brown bleeding. So around the period, women will say if they're just having red bleeding, or they just chart that. But if they're having brown bleeding, they're usually instructed to chart that specifically. Limited mucus cycles are common. So there's usually right around the ovulation, leading up to the ovulation, you're supposed to have a buildup of mucus. So a lot of times with endometriosis, you might see no mucus, or just very limited, not very many days of mucus and small amounts. Sometimes we just see shorter menstrual cycles overall, or if we do blood work and check hormone levels, commonly the hormone levels are low. But not everybody follows the rule book, but those are the common things we see.
Mm-hmm. So obviously, from your perspective too, as a physician, the charting is a good place to start to help you kind of lead down the diagnostic route, obviously with labs that you might need to be drawing or imaging that you might want or whatnot.
Yes, yeah, so it can definitely help lead us in that direction. Yeah.
Yeah. I often tell the patients that I work with that your charting is like the border of a puzzle, right? You never start at the middle of a puzzle when you start putting the pieces in, because that would be really overwhelming. But you start on the border and then it kind of fills in the picture.
Yeah, I mean, for me as a physician, it's an essential piece of the puzzle. If a woman is coming to me and they're complaining of some sort of symptoms, the women that do have a chart and that we can look at that, it just gives me a lot more to work with.
Mm-hmm. Yeah, definitely. And I would hope in the long run, more expedited treatment, right? Just having that information.
Oh, yeah.
Yeah.
Mm-hmm.
Definitely. So we know that endometriosis has differing levels of severity, right? Like you said, some people don't even know they have it. And Some people have a lot of symptoms. But what is the treatment for it? And at what point is intervention recommended for endometriosis?
So we can kind of go over some of the more like traditional treatments that are used, and then some of the different things that are done in restorative reproductive medicine. Traditionally, women that are having, you know, because a woman that is not having any symptoms at all, she's probably not going to be even looking for treatment or going to the doctor unless she all of a sudden is having infertility. Okay, then she may be going to the doctor. But for a woman that's having symptoms, usually the reason they go to the doctor is because of pain. So the first thing that's usually done is take some NSAIDs like ibuprofen or Aleve. That's kind of the starting point. Okay, when that doesn't work, we go a little further. Most doctors at that point offer birth control. And the idea behind that is endometriosis is thought, one of the thoughts about it is that it's driven by the hormone levels, because typically the pain is worse around the time of the period. Some women with endometriosis have pain their entire cycle. They have this chronic pelvic pain. And so with birth control, they think, okay, we turn off the cycle, things will get better. The thing that stinks about birth control is while it can be a good form of pain relief for some, it does nothing to actually cure the endometriosis. So you could still have that disease process going on and maybe even progressing and not doing anything about it. There are some newer medicines. They fall into the family of, it's called GnRH agonists, and they also work by messing with your menstrual cycle and turning it off, and actually create sort of a menopause-like state. So they have really terrible side effects, but those are kind of some of the approved medications for endometriosis. That's not something that I do or something in the restorative reproductive medicine world. Birth control or these GnRH agonists would not be used. So, okay, let's talk about some other things that are used. You know, if there is some sort of hormone imbalance that we find in blood work, that's something that we can work on. There are some supplements. I think we're going to talk about that a little later. There are some kind of lifestyle interventions that can be done. And then really, if we really want to definitively say we need to treat this, you're going to have to move to surgery. And that's not something most people like to hear. Surgery's, you know, not just a walk in the park. But the definitive treatment is surgical excision. So that's, you know, the surgeon is going in and cutting out the lesions, the endometriosis. And when you're getting this type of treatment, you have to be very careful about who you go to. You have to go to a good surgeon and one that's been trained specifically, kind of had some extra special training in this type of endometriosis surgery. So one of the more basic things is that they can choose to remove the lesions through excision, like I mentioned earlier, where they're cutting it out, which is that's the better way to do things. Some surgeons will use ablation, so that's an important question to ask the person you're seeing. You know, do you use ablation? Because that's where they just burn off the lesions, and it doesn't work as well. And so depending on the type of surgery you get and the quality of the surgery, you could come out of that with all the endometriosis removed and with you feeling a whole lot better. And then if fertility is your goal, you know, potentially helping you get pregnant. Or if you don't have the best quality surgery, you may not have the symptom resolution that you're looking for. Another thing that's different about the traditional approach, and doctors that are more in the camp of the restorative reproductive medicine in the surgery perspective too, is some traditionally they might put you on some either birth control or like before surgery, and then have a plan after surgery to continue birth control. And some people have the opinion that, well, you know, I'm going to go in the pelvis and I'm going to clean up some of this endometriosis, but you know, if I don't get it all out, or, you know, that birth control will kind of take care of some of it too. But that really is not the best way to do it. You want to, people in the restorative reproductive medicine world with this sort of approach, they, you know, don't use birth control. And one thing, you know, when you have someone that's not even having that frame of mind where they're thinking, okay, I'm going to clean it up with this other medication, they're probably going to do a lot better job at making sure they get everything out of the pelvis. And not to mention that that's the better way to treat it anyway. So yeah, there are some things you can do before you jump straight to surgery, with some lifestyle changes for sure. But for some, you have to be careful that you don't delay that for too long. And one thing that's so tough is it to be diagnosed, you know, you can assume based on your symptoms that you're having, maybe some things we're seeing in the charting, you can assume that, okay, maybe I have endometriosis, but you can't know for sure unless you get that sample from surgery. So that's another reason to maybe look sooner than later, because, you know, on average, it takes a woman about 10 years to get diagnosed. That's a long time to be suffering, you know, with these symptoms. And so sometimes, you know, it's kind of a decision that each individual has to make for herself, and kind of each case is going to be unique and different. And but you know, I would not want anyone to be afraid and postpone surgery and miss that diagnosis or potential, you know, treatment that can be gotten there. So yeah, I guess I hope that answers totally.
That was really good. I just learned a couple of things too to add to my toolkit, you know, just information. And if you like, I've heard that before, that it takes about 10 years from, you know, to actually achieve a diagnosis of endometriosis. And I think, like you said, when people hear surgery, they're like, no, it doesn't have to be surgery. You know, like that's like a scary word or a scary treatment thing, to approach. But the truth is, when it's gone and it's done well and meticulously by a really well-trained surgeon, the quality of life improvement after that is significant. So delaying, you know, what could be a really beneficial treatment, even if it's surgical, you know, in the long run could just leave people with symptoms for longer, which again, there are a lot of women that suffer with symptoms and their whole lives are ruled by their cycle, which is really unfortunate. We don't want that for anybody.
Yeah, and you know, another thing to take into account too is all pelvic pain and all period pain is not endometriosis, and there are other diagnoses that either you know, you would want to rule in or rule out, and you know, doing the surgery would tell you, okay, do I have it or do I not, and then that would guide, you know, your future kind of decisions about how to live your life or what to do, you know, if you had endometriosis or didn't. And then if you don't, okay, well, maybe we need to look at other approaches. So that, you know, another reason to kind of get to the bottom of what's going on.
Yeah. And for somebody who's listening to this, I'm curious, what is the risk of not seeking treatment? You know, kind of letting it go, just kind of putting up with symptoms for the rest of your life, never maybe getting a proper diagnosis. What's the physiological risk of that delay?
Right. Yeah. So it can progress, you know, it can get worse. That would be one risk, is that maybe you're having some pain now, but 10 years down the line, is it going to be a whole lot worse and more disabling? Another risk is that maybe you're not ready to get pregnant right now, or you don't even, maybe you don't think, oh, I don't think I ever want kids. And then 5 years down the road, your opinion changes on that, and you do desire pregnancy and you've ignored these symptoms. You know, if you had gotten that endometriosis taken care of sooner, that's going to make your fertility better for the future. So that's another thing to consider. And, you know, with the whole other thing to think about is, okay, maybe I'll just make it to menopause and I'll feel better. And for some people that is the case, you know, but there can be, you know, there have been, you know, documented menopause I'm sorry, talking endometriosis after, still kind of lingering things. And then the other thing that you definitely can't discount is the mental health component. Because endometriosis is a chronic, usually it's a chronic disease. It's something that plagues you for over time. And it's a disease that involves pain. It can really affect the mental health of the person. And that's another thing. So, if you're kind of leaving this untreated and just dealing with it all the time, how are you doing with your mental health, and how is that, affecting you, and are you taking care of that? And maybe if you were to try to, treat the problem and deal with it with that, would you feel better, and then mentally, feel better?
I think that the mental health piece is significant, not only, like you said, just for dealing with the symptoms, but also the question of why. Like, why is this happening?
Right. Explaining, yeah.
Yeah, that question, I think, plagues women sometimes more heavily than symptoms. They're like, why is this happening every month? Why am I so, overwhelmed or get anxious about my period coming? What's the why behind it? I think that's just as a human condition, that's our quest, is to know, like, why are things happening, especially when it involves your own body. Right. So, well, I thought that overview was really, really helpful, and I appreciate the kind of just compare and contrast of the traditional versus restorative approach. I think that was really helpful. I think one takeaway a lot of women ask me is, are there natural therapies or lifestyle approaches that can help alleviate some of the symptoms that they might be feeling? Curious what your thoughts are about that.
Yeah, so I love that you asked me this, because I actually in residency did a little research project on this question specifically. I gave a presentation, integrative approaches to endometriosis. So I have a blog post on my website that's just basically pulled from that presentation, and it lists out some supplements that have been shown to be beneficial. I'll give one example is N-acetylcysteine. Is actually in a study was shown to decrease I said earlier that endometriosis can only be diagnosed through surgery, and that's usually the case. But every now and then, for somebody that has a really bad, something they call an endometrioma, like a large growth, sometimes you can see that on an ultrasound or an MRI. So that's one way to get out. Then you still may need surgery to remove it. But so they did a study, and they found that taking the N-acetylcysteine over time reduced the size of the endometrioma. So that's pretty impressive. And then so that there's a few other supplements that I've listed there that can help. Some of them are targeted, like the N-acetylcysteine can specifically help endometriosis, and others are more just to help with pain. And then another big one is pelvic floor physical therapy. There are some physical therapists that specialize, even specifically in endometriosis, or definitely you want to find one that has done some training for the pelvic floor. That's a big piece of the puzzle, because once again, you may have endometriosis, but you may have some sort of muscle tightness or some other, there can be other things going on along with the endometriosis that might contribute to your symptoms. So that's really beneficial. Acupuncture can be beneficial. So there's some different things, that I've kind of listed out in that blog. And then I'll just say it again, if you feel that your mental health is suffering, meeting with a therapist or taking care of that side of things too, because once again, having a chronic pain condition is something that you have to, if it's not going away tomorrow and you're going to have to keep dealing with it, you have to figure out how you can, live your life with, with this.
Yeah, that's a really interesting view you've just helped us orient to, is that, for women who suffer from pain, this is chronic pain. Where, a lot of people talk about their chronic back pain or their chronic knee pain, but for women, this is legitimate chronic pain. And,
Right.
And unfortunately at the height of it in the reproductive years, when we're young, healthy, trying to really, use our body to achieve our goals and whatnot. So that can be really, really, I can see that being hugely affect mental health. So I love that you just offered that perspective, because I think we so often discount that women experience pain in that way, and it's chronic, you know.
Right.
So
And
that,
it's just hard because the whole conundrum of like, is period pain normal or is this an abnormal, you know, because everybody may have some level of discomfort when they're, you know, having their period, but, you know, what is an acceptable amount and what is really, okay, this is not something that's normal.
yeah, and that's, I feel like that's a kind of a hard question to ask sometimes because people experience pain differently, you know.
Yes,
Yeah, well, that was really helpful. And for anybody who's watching this, we will link in the comments to the blog so that they can get those resources from your studies. So if this video is resonating with anybody who's watching it and they suspect that they might need to look into this personally, what would you recommend that they do? Where do they start?
Yeah,
That's a big question, but
educate yourself. That's just so huge. I mean, I've heard other people say this, and it's something I really believe too, is, you know, nobody's going to care about your health as much as you do, you know, and so you do, you know, you're going to get better health care if you advocate for yourself. And that means you have to know what, you know, you have to educate yourself and know what to look for and what needs to be done. And so I'll, you know, mention a few good resources. The Nancy's Nook website is a popular one for endometriosis, and they're really, you know, I had never looked at it before, and I was looking at it the other night, and there really is a lot of good information on there. And on that website, they have links to other websites, so you could kind of use that as a landing page to start to dive in and just learn more about endometriosis. Another important things, learn how to chart your cycle. So you know, we call these fertility awareness methods, the different, you know, charting methods. And you learn so much about your body through doing that. And it's like, you just get this information, and it's like people say, it's like a vital sign. It's a guidepost. It's a information to help you know, is my body doing what it's supposed to, or is something going on here? You know, it just, that way it's a practical way to plot it out so you don't have to question, you know, you sort of see it on the chart, you know what's happening over the month and if things are looking the way they're supposed to look or not. And then, you know, once you do learn how to chart your cycle, then if you do feel that you need medical attention, you can go and find a doctor that understands this approach and can help treat you, you know, in this way. And then another resource I really like, I could send you the link for it. The St. Louis University has something on the internet, an anti-inflammatory and elimination diet for adults living with endometriosis. So it's this long handout that has some dietary tips in there. And yeah, so those are kind of, that's where I would start.
Yeah, that's fantastic. And for any listeners who are suspecting, you know, maybe some underlying things that they want investigated about, maybe endo, again, one of the most common treatments is birth control, right? So there might be a lot of women who are on birth control currently for those symptoms. And I just encourage those women, if you want to help get to the root cause of what's going on, it does require sometimes that we have to eliminate birth control as the alleviation of symptoms. Right. And in order to do that, I think there's a lot of times this like this nervousness of symptoms coming back.
Oh yeah.
And so right. I guess kind of on top of the resources with that, finding a restorative physician to work with as you go through that process of getting off birth control, and at the same time having a fertility educator who can work with you to learn how to chart your cycle during that transition, I think that's really important too. Because getting to the root cause requires us to take away some of those, you know, suppressants like birth control, which can be hard.
Right. Yeah. No, I mean, and not only just important, but really needed, because once again, if you have endometriosis and you've been on birth control, it may be helping to control your symptoms, but it's not treating it. And that, you know, right there is, you know, because when you get off the birth control, if all the symptoms come right back, well, okay, the endometriosis is still there, you know, so as if you're in that position where you're wanting to stop taking birth control and try to maybe approach this from a, okay, let's solve and fix the endometriosis, or then I think you would definitely want to have a physician and you know, learning how to chart your cycles and doing all that. You would want that help and that guidance to help you deal with the symptoms that you and the things you may be going through as you make that transition.
Yeah. Yep. And you need people on your care team. I always say, like,
Yeah.
I'm on your care team. If I'm your educator, right, we'll connect you with a physician who can treat you in a restorative way. That person will be on your care team as well. Like, it really does take a village to get to the root cause of what's going on in women's health. We're not, I think, you know, in traditional women's health, we always haven't had that that ability, or we haven't been able to look at our health in that way, but it really does take a team. So I am going to post so many resources in the comments. People won't know what to do with it. So they will be there and available to anybody who's watching this. And obviously, feel free to email Dr. Anderson, me, whoever, if you need some more resources so we can connect you to the right people to help with treatment. So this was really interesting conversation. I learned a lot. I'm sure anybody who's watching this is going to learn some things as well. And again, we just appreciate your time and educating us about our bodies and like how amazing they are and what we can do to optimize them. So thank you so much, Dr. Margo. There we go. Sorry, our internet was cutting out right when I was thanking you.
Yeah, froze for a second. Yeah. No, it was awesome speaking with you. I always enjoy our conversations.
Yeah. All right. Till next time, ladies, we'll come up with something even more exciting to talk about. So we'll see you next time. Thanks, Dr. Margo.